second, I'm going to try and come up with a nice review for you guys. Tuesday is our last lecture of the block, and you guys get a whole, like 5 days, 6 days to study for the test? Nice. Well, I mean, minus whatever test you have before that. But I'm going to try and do your review right after the lecture so that I don't pontificate and I shorten the lecture, just giving you the spots that you need to know. And then we can take a little break and then go through the review for the block. So bring your lunches, we'll have potty breaks and go from there. All right, without further ado, and thanks for waking me up early this morning. We got our test conditions and standards. And so just a little review of the anatomy and physiology of the stomach. So you've got the cardia, which is the top of the stomach. The fundus, which is the top portion of the rounded portion of the stomach. Serosa covers the stomach, and then you've got the body, which is the main portion. You've got those three muscular layers. Oh, see, I can't do technology. You got those. No, never mind. We're not going to do technology. So you got the 3 layers of the stomach. Take a special note of the pylorus, duodenum. And then see how the inside of the stomach has the rugae or rugae, however you want to pronounce it. And so you've got all those areas for food to go into, where you've got that little mix and things are happening inside there to digest your food so that it goes through the rest of your stomach. And so I put this on here because we've got some histology. Different cells do different things. But I want you to pay close attention to the parietal cells, chief cells, and the G cells. Parietal cells secrete hydrochloric acid and intrinsic factor. And what does intrinsic factor do?
Absorb B12 and pull it.
Yeah, so it protects the B12 and packages it so that it goes through the rest of the system and gets reabsorbed into the small intestine. And then you've got the hydrochloric acid, which is important too, right? So that's going to help break down all your food and mix it up into smaller particles. And then your chief cells secrete pepsinogen, which does what? What does it convert to in the presence of hydrochloric acid?
Pepsin.
Pepsin. And so what does pepsin do? Breaks down your proteins for your keto diet, right? And then your gastric lipase also helps break down your lipids so that into smaller packages so that they get absorbed further into the gut. And then the hormone gastrin. What does gastrin do? What? Well, no. Gastrin's a hormone, right? And so right before you eat, the vagus nerve stimulates your stomach to release gastrin. And then gastrin, see, I had to write it down because I'm not that smart. It stimulates the stomach to release hydrochloric acid. And so it also stimulates the gallbladder to release its stuff and the pancreas to release its enzymes. So it's a whole process with gastrin. And so if I've got a tumor, a gastrin tumor that's releasing a bunch of gastrin, I'm going to increase my hydrochloric acid levels, right? And all these other enzymes are going to be going out, and that can cause tissue injury. You guys agree with that?
Mm-hmm.
That makes sense? Okay. Moving on. So hiatal hernias. You guys have all heard of hiatal hernias. It's the most common type of hernia. Your patients are going to present with GERD. And so you're going to treat their GERD initially, because we're not going to do a bunch of studies unless we have to, and they start having prolonged, protracted GERD that's not responsive to your therapy, or they're having additional symptoms, or they're having those red flag symptoms or those alarm symptoms, right? And we've got hiatal hernias classified as sliding and paraesophageal. And so the sliding hernia is just a displacement of the GE junction or the gastroesophageal junction above the diaphragm. And so when that junction's above the diaphragm, you're still releasing that hydrochloric acid in those columnar cells. And then you have your rush of hydrochloric acid up into your esophagus, causing that GERD-like symptoms. And so that's your most common type, okay? And then you've got the types 2, 3, and 4. And unfortunately, my cool little pictures didn't transmit through. But type 2 is you've got a hernia sac. And so, let's go over here. So you've got the type 1, the sliding hiatal hernia, and then you've got the G junction stays down in type 2, and then you just have part of that fundus or the greater curvature popping up through that junction in that diaphragm. And so that slides up and down. And sometimes it, in some cases, it can incarcerate. So if you have portions of tissue inside of a ring that can't escape, that's an incarcerated hernia, right? And so that's bad juju, just so you know that can happen. Type 3 is where you have the sliding hiatal hernia as well as part of the paraesophageal hernia. And then type 4 is where you have stomach contents and all kinds of abdominal contents that can go through that ring. Because that ring's super expanded, and so you can have small bowel, you can have large bowel, you can have a lot of stomach that just goes through that diaphragm into the chest cavity. And so their x-rays obviously look super weird, right? You don't have all those like claustrophrenic angles. You got like one side that's higher than the other. And I had pictures for you, but unfortunately, no internet. And so your hiatal hernia classic presentation, GERD. Your physical exam's typically unremarkable, so you're not really going to find anything. You may have some TTP in that epigastric abdomen or the left upper quadrant, but likely not. Physical diagnosis commonly found incidentally on upper GI endoscopy during your GERD workup, or barium swallow is most sensitive. So you have somebody who's got long-term GERD, and then you give them the barium swallow test, and you'll see a little bit of that stomach herniating through that ring, and so it kind of looks like it's curvy on X-ray. Okay. Treatment for small hernias, we just do the GERD management. For large hernias, refractive to treatment, we do surgical repair. And what's the surgery?
Fundo, with the rocket around one?
Yeah, the Nissen fundoplication, right? That was a fun one to say. Nissen, you guys ever watch Grey's Anatomy?
No.
So gastropathy versus gastritis. So histologic difference, gastropathy is mucosal damage without inflammation, and then gastritis is mucosal damage with inflammation. So pretty easy to differentiate there. Gastritis is commonly secondary to infectious or autoimmune etiologies. H. pylori is the #1 cause usually of gastritis. Gastropathy is common secondary to endogenous or exogenous irritants like alcohol, NSAIDs, physical stress. So the ICU patient or people who are super sick, those get gastropathy. Mucosal biopsy is necessary for diagnosis and differentiation. So most common NSAIDs, alcohol, significant stressors, mechanical ventilation, prolonged surgery, trauma, burns, shock, sepsis. These are all super stressors on the body. And when your body's super stressed, you release a lot more hydrochloric acid, and you have a lot more things in coagulopathic patients. Now they're even at higher risk because they can have bleeding ulcers. Okay, and then portal hypertension. So similar to the esophageal varices, you can get varices in the stomach as well. And so your signs and symptoms: patients may be asymptomatic. They may have non-specific, so anorexia, epigastric pain, bloating, nausea, so they just don't want to eat. They're not super hungry. Their stomach, like it sounds like dyspepsia, right? Physical exam, again, typically unremarkable. Diagnosis via endoscopy for dyspepsia or upper GI bleeding. Okay. So let's talk a little bit about NSAIDs, gastropathy, because that's what your number one prescribed medication is going to be, right? You guys agree with that? And so patients receiving chronic NSAID therapy are at higher risk for gastropathy, and I'm going to tell you why in a very brief overview. And so these are our frequent COX-1 inhibitors, and so we do a lot of Motrin, we do a lot of Aleve. Indocin, you guys just learned about that. I caught that tail end during your pharmacology review. And then I've seen a lot of diclofenac lately as well. It's not one of my favorites. And then, so we talked about what a prostaglandin is, or did we not? We didn't. And so lipids derive from arachidonic acid. Did I say that right? Arachidonic. You probably had somebody smarter say that name. Doesn't really matter. It's generated by the action of the COX isoenzyme. They play a key role in generation of inflammatory response. And so there's a lot of studies done recently that with some orthopedic injuries, decreasing that inflammatory response isn't always a good thing, right? So your body has that inflammatory response bringing in all the mediators and helping fix stuff. But we still throw an NSAID at it because that helps them feel better, right? Decreases that inflammation, decreases that swelling. So we do a lot of that prescribing. And so the gastric prostaglandins stimulate the epithelial cells to release more bicarbonate and mucus. And that's important too. So I've got this bag full of hydrochloric acid. How does it protect itself? Well, with mucus and bicarbonate. So I'm not, burning up all the tissues, right? And it also reduces the permeability of the gastric epithelium, and then this reduce of acid-back diffusion. And so that's where your cells reuptake that hydrogen ion, and then it can cause some burns that way as well. It acts as a potent vasodilator, increases mucosal blood flow, increases resistance to injury, and helps the stomach grow, tissues grow. This is the NSAID's mechanism of injury. You guys have seen this already. And then what it does to the stomach, so you got that NSAID, those COX-1 inhibitors, reduce the mucosal blood flow, impair defense, and then cause mucosal injury and bleeding. They reduce mucus bicarbonate secretion, impair defense, and then result in mucus injury and bleeding. And then impaired platelet aggregation. So now if I've got an injury and a bleeding, now my platelets are impaired, and so they're not going to clot. And then the NSAID itself causes epithelial damage. Remember we talked about that pill-induced esophagitis yesterday. So it's a little acidic on its own, and it can cause some damage locally. Acid-back diffusion, platelet aggregation impaired, and then mucosal injury and bleeding. The COX-2 does some stuff too, but it's not as effective. It doesn't hurt the stomach as much as the COX-1 inhibitors. Okay. So some signs and symptoms of NSAID gastropathy. Dyspepsia is the most common presenting complaint. Treatment is PPI for 4 weeks and discontinuing the offending agent. And so I want to reduce the COX-1 inhibitors, and I'll probably give them a COX-2. Somebody give me one COX-2 med. Celebrex, another one. Meloxicam, right? We don't care about any of the other ones. Somebody else. So you want to give them something that's longer acting and a COX-2 inhibitor, and then you want to give them the lowest dose that's effective. Okay, so instead of throwing somebody with the 15 milligram meloxicam once daily, you might start them at 7.5. Okay. So if the NSAID treatment must be continued, so like I can't handle my life without my NSAID. We can make sure that they're taking it appropriately. So we always take NSAIDs with a milk or a food, right? And then the sucralfate and the misoprostol, those are additives that we can give people that are taking NSAIDs. And the sucralfate actually coats the stomach lining, helps protect it from the NSAID. And the misoprostol is a prostaglandin. And so it's a synthetic prostaglandin that helps the bicarb and all the other things. So I'm not talking about mechanism of action with you guys. You guys get that somewhere else, right? So if symptoms do not resolve or improve, or there's alarm symptoms present, then I need to send them to GI for their upper endoscopy. And so those alarm symptoms: severe pain, weight loss, evidence of GI bleeding, and anemia. So alcoholic gastropathy, those alcoholics, they usually get some stomach upset, right? And so that the ethanol has a direct toxic effect on the gastric mucosa, and it also impairs gastric motility that leads to delayed gastric emptying. So that's why people want to vomit, right? Because the things don't go down the tube like they're supposed to. And this leads to prolonged contact with the gastric mucosa, which results in injury. And so this is seen in the chronic alcoholics. They usually have dyspepsia, nausea, vomiting, minor hematemesis. If that continues, what kind of tear do they get in their salary-wise? Here, look at you guys, so smart. Treatment is discontinuing the offending agent. Oh, stop drinking. Who's going to listen to you with that? And a PPI for 4 weeks. I don't know, anybody hear of Warrior Heart? No? Warrior Heart is some Delta dude, like, bought a bunch of land and created this, like, retreat for military. You got your first responders and some of your police force. And it's a 6-week program that they send people with alcohol and drug-related issues. And they've got a lot of active duty that they're sending over there. And so it's like a 6-week instead of inpatient. It's more of like a group therapy kind of thing. So remember that for your dudes and dudettes. All right, so stress gastropathy, seen often in critically ill patients. The highest risk of significant bleeding is associated again with coagulopathy, respiratory failure with mechanical ventilation. And I told you guys, like, you know, ICU as a PA sucks. That's like one of the worst jobs I've ever had, because you're basically like practicing medicine. You're throwing meds at them to keep them alive, see if it works, and trying to keep them alive until day shift problem, right? So that the physician on call can call time of death, you know, so it's a very stressful job. So not fun. But those guys, if they're mechanically intubated and breathing, they don't have a lot of movement of the gastric acid, and so they develop ulcers and bleeding ulcers, especially if they're coagulopathic. And so we want to make sure that we treat that, or in our order sets when we're admitting somebody to the ICU, we want to give them what? I got it right here. IV PPI. And so most of the time you find Protonics is pretty cheap, and so the government ICUs usually use Protonics. And so that's got a 20 milligram and a 40 milligram. And so normally we just give them, like, you know, 40 milligram once daily, but if they've got some history of ulcers or bleeding, usually it's a BIV that we give them 40 twice a day, and that kind of helps suppress the acid. And then, you know, oral sucralfate through their OG tube. So if they're intubated, they've always got an OG tube that's decompressing their stomach, right? That we can feed them with, or we can do flushes, water flushes. So if I give them that orally, it'll help protect the stomach lining by coating it. All right. Portal hypertensive gastropathy kind of looks like the esophagus or esophageal varices, right? You've got these tortuous veins from portal hypertension. And so it leads to pathologic increase in mucosal blood flow. And then you've got a high risk of bleeding, just like you do in the varices, but they don't bleed as much as the varices. So there is that. You use the beta blocker to lower portal pressure, and so the beta blocker that I talked about yesterday was propranolol, and so there's a couple other ones that you can use for that. And then the treatment for the portal hypertension is more to follow when we do the liver next block. And so gastritis, this is inflammation and mucosal injury, right? And so I love this slide. You got your little H. pylori dude that's, kind of evil. And so it's a gram-negative curved rod. They synthesize urase, which produces ammonia. That damage the gastric mucosa, and then the ammonia also neutralizes acid pH, which allows the organism to live in the stomach. And so it's adding things that your mucosa is not adjusted to. And then we know our three medications, right? We got our PPI, clarithromycin, and amoxicillin. All right. So how is that H. pylori transmitted? It's usually person-to-person, close contact, eating with infected utensils, you share, swap and spit, right? So if one person has it, usually their spouse or their significant other also has it. And so it causes gastric mucosal inflammation. On histologic, so you'll find the mucosal inflammation with the PMNs, so the polymorphic neutrophils and lymphocytes. Patient presentation is related to dyspepsia. Up to 35% will be asymptomatic. And so testing is indicated for those dyspeptic patients, those chronic GERD patients, and suspected or confirmed peptic ulcer disease patients. And so what's the gold standard? The poo, right? The stool antigen assay or fecal antigen assay. So you see the sensitivity is 94%, specificity is 97%. Their urea breath test, not always available. Now you got to drink something, take a pill, wait a while, and drink some more, wait a while, and then breathe into a balloon and send that off to the lab. The sensitivity is 88 to 95%, and specificity is pretty specific. And then H. pylori serology, you see it not very sensitive and not very specific and not recommended for routine use. The endoscopic diagnosis is reserved for those with alarm symptoms or patients refractory to treatment. That makes sense to you guys? I'm going to treat them empirically. I'm going to do the stool test. But I'm going to save those specialty consults for those people that have plus that, right? So, or if they don't respond to my therapy or they got those alarm symptoms. Patients should discontinue any anti-secretory therapy for 14 days, and then we shouldn't do and this is for the initial test. That bismuth and those omeprazoles are going to skew my testing, so I want to stop those for 2 weeks before I test them. And then I need to do a test for cure to make sure that I've eradicated it, and I got to do that at least 28 days after the antibiotics, because if I don't, that'll also skew the tests. And so we talked about this too, right? You guys good with this slide? We know the standard quadruple therapy is reserved for those areas that they've got antibiotic resistance. And they're also with that fecal antigen test, they're coming up with the additional testing that PCR is the antibacteria or the bacterium, and sees if they are sensitive to antibiotic or not. So you may also get like the sensitivity of the organism to antibiotics as well as with that report. So that'll help you determine what they're going to do or which medications are going to prescribe them. Atrophic gastritis, so metaplastic, I talked about that, right? You've got one cell that changes into another cell. And that can form chronic gastritis in addition to inflammation. I've got mucosal thinning and then loss of specialized cells. So if I lose some of my parietal cells, now I can't bind up my B12. Now I'm at higher risk for what? What kind of anemia? Pernicious anemia. They're so smart. Typically from prolonged H. pylori infections. rarely from prolonged PPI, and then maybe idiopathic in elderly. And so I've got a bunch of stuff written in the comments for this. So you've got like the autoimmune, and then you got environmental factors that can add to the atrophic gastritis. Do I need you to know about it for the test? No. That's just for the geek in you if you want to learn some more, okay? And so pernicious anemia gastritis, autoimmune response to gastric parietal cells resulting in lack of intrinsic factor and vitamin B12. And then you got the infectious gastritis, so that's bacterial infection, viral funguses, seen most often in the immunocompromised, so your HIV patients, your chemotherapy patients, people who are on chronic steroids. Eosinophilic, so we talked about the eosinophilic esophagitis, but you can also get it down into the stomach, but it's super rare. And then they got the abdominal pain, early satiety, and postprandial vomiting. And they probably also have the eosinic esophagitis as well, because it doesn't make any sense it would be in one place and not the other, right? Meniere's disease, I was going to give you the French accent, but it's too early. It's an idiopathic hypertrophic gastropathy, and so you got these big old mucosal folds inside the stomach, and that can affect some stuff. So I don't need you to know all about it, but if you want to read about it, look it up on Google. All right, peptic ulcer disease. You guys want to take a little break or keep? Well, that was only like 22 minutes. All right, we're going to keep going. So peptic ulcer disease is a defect in the gastric or duodenal mucosa due to impaired mucosal defense mechanisms. And so those will present differently. You probably should know the difference between the two. High prevalent disease, 500,000 new cases every year, and 4 million recurrences in a lifetime. So duodenal ulcers, most common in younger people, and so 30 to 55, but those rates are declining a little bit since we're eradicating H. pylori, because that's your #1 causative agent. And the older patients get the gastric ulcers, and that's increasing due to more NSAIDs and aspirin use. And so etiologies, NSAIDs and H. pylori. The other ones that can affect this is hypersecretory conditions. So if you have a gastrinoma, that's increasing your hydrochloric acid production and causing more ulcers. CMV, chronic disease states, Crohn's disease, and lymphoma. We're going to talk about Crohn's disease a little bit later, not today. Signs and symptoms of PUD, dyspepsia, so that gnawing, aching, hunger pain. It's cyclical in nature, nearly immediately with gastric ulcers. So when they start eating, they start getting that pain and discomfort or those dyspeptic symptoms. But with duodenal ulcers, it's usually 2 to 4 hours postprandial where they get those symptoms. Often report relief with food or NSAIDs and may complain of nocturnal pain, more frequent with duodenal ulcers. So there's a circadian rhythm associated with the release of hydrochloric acid. And so like between 11 p.m. and 2 a.m., you release a lot more gastric acid, so that'll irritate those duodenal guys. And so they'll wake up with some belly pain. Up to 70% of ulcers are asymptomatic. And then they may present to you with bleeding or perforation. So gastric versus duodenal ulcer. The gastric ulcer, increased pain with eating, and duodenal ulcer, decreased pain with eating. Why also decreased pain with eating? Yeah. So after it leaves the stomach, you've got this like bicarb wash on that food that decreases the acidity of it, so it doesn't injure the rest of the mucosa going down the tube. So perfect. And so history, inquire about NSAIDs H. pylori infection. Again, physical exam is typically unremarkable, plus or minus epigastric pain to palpation. Positive fecal occult blood or FIT test in a third of the patients, so they may already be bleeding a little bit. And so occult blood, you don't, remember I talked about that, you don't see it and you don't know about it because you could lose up to 3 shot glasses a day and not have anemia from it. And then those fecal cold blood will tell you that there's something in there that's bleeding. Any alarm signs warrant immediate endoscopy and referral. Okay. What are our alarm signs? Yeah, vomiting, that's one that you probably didn't get, but you got your night sweats, your unintended weight loss, all the other good stuff, and then older age, right? Your workups, you're going to do the CDC for anemia, fecal occult blood, evaluating for occult bleeding, H. pylori testing. If PUD is found on endoscopy, biopsy will be taken. So, like if you've already sent them for endoscopy, they'll let you know if they're H. pylori positive or negative, and then you treat them. And then, so your EGD is going to be your test of choice for both procedure for bleeding ulcers and for determining if they have. Look how ugly those are. So you got these pits that are basically destroyed tissue, right? Gross. Anyway, so treatment, NSAID related, again, you want to discontinue the NSAID, titrate to the lowest effective dose of your COX-2 inhibitor if you can. And then H. pylori ulcers, you're going to treat for the H. pylori. Okay. General treatment, so anti-secretory, I want the PPIs. So if I've got an H. pylori infection, I want to continue those PPIs for like 2 to 4 weeks after the duodenal ulcers are treated, or after the antibiotics are completed for duodenal, and 4 to 6 weeks for the gastric ulcer H. pylori patients. And then again, the mucosal defense, the Carafate or sucralfate has a viscous protective layer over the stomach, and then the Cytotec is a prostaglandin analog. You use that for long-term NSAID patients. It's a nice one to throw on there. Peptic ulcer and general strategies. So you're going to tell the patient, eat meals at regular intervals. Avoid meals right before bedtime, right? Because they'll have those GERD and that dyspepsia feeling. And then stop smoking and stop drinking. Stop taking your NSAIDs. All the stops. Acute upper GI hemorrhage is a complication of the peptic ulcers. High incidence of bleeding from the ulcers, but low mortality because they don't typically bleed as much as they do from like the esophagus. Let's see, hematemesis and melena. So what's melena? Dark stools, right? Dark tardy stools. Hematemesis, throwing up blood, right? Or coffee ground bleeding or bright red blood, depending on what you have. The treatment is endoscopy for hemostasis. And so ulcer perforation results in chemical peritonitis. So if you've got a perforated ulcer, whatever was in your stomach is now leaking out into spaces it shouldn't go. And that's going to cause a peritonitis. So they're going to have sudden severe abdominal pain, rigid abdomen, reduced bowel sounds, because anything that touches like the small bowel, it tends to freeze it, like it's like a deer in headlight, right? So don't touch me. And then they're going to stop moving, so they're going to also be vomiting. Pneumoperitoneum, so you'll see some air underneath the diaphragm, and then the workup includes abdominal CT. And so you see a pretty significant air underneath the diaphragm. That ain't right. That's wrong. If you don't even know what that is, you know it doesn't look right, right? All right, and so if you see my positive arrow sign, that's an abscess from a duodenal perforation or perforated duodenal ulcer. And if you see around that, you see that stranding? Yeah, so stranding is also badness or something that the surgeons like to look for, because that's inflammation around things as well. And so you got an abscess with stranding. And then you got some air that's not where it's supposed to be in the CT. So that's a pneumoperitoneum. That's air inside the abdomen. Ulcer perforation up to 40% seal spontaneously. But I don't want to keep things leaking out where it's not supposed to go, right? And so what I'm going to do is I'm going to give them some IV fluids. I'm going to drop an NG tube in them so that I can keep their stomach decompressed. I don't want all the liquids and all the hydrochloric acid in there making things worse. So I'm gonna hook them up with an NG tube onto low walls, is it intermittent suction? Because I don't want it continuously suctioning, so I want it intermittently suctioning. Give them the IV PPI, some antibiotics, because they're leaking into areas where they're not supposed to be leaking. And then surgical repair if perforation with evidence of free air, also the peritonitis and deterioration of the patient while admitted. And what the surgeons do is they basically open up or laparoscopically go in and then sew the omentum on top of the perforation. So it's kind of cool. If you think about it, surgery is pretty archaic, right? You know, you got your positive trauma to go fix stuff. Like, who would have thought that would have worked, right? But, you know, hey, we've got a lot of people living because of it. Ulcer penetration, this is also bad. And so you have a patient that has an ulcer that basically burrows through the stomach and into another object that's around it. And so this can happen to the pancreas, liver, biliary tree, and so that's all bad. Patient will report change in their typical peptic ulcer disease symptoms, change in frequency. Sometimes the medication won't work at all, and they may have like that pain, that epigastric pain that bores into the back, and they're not an alcoholic. And so now you gotta search for reasons, right? Additionally, gastric outlet obstruction, and so if you have ulcers that are down by the pylorus, you have change in your cellular structure, and so you start having scar tissue that can, just like you've got the esophagitis with those chronic GERD symptoms, you have that chronic acid. That's the same thing. You got scar tissue from your ulcers that narrows that tube. So your symptoms are early satiety, postprandial vomiting, they'll vomit undigested food contents, gross. Treatment is endoscopic dilation, and so they can either do like the bougie or the balloon that we showed before. Zollinger-Ellison syndrome is a gastrinoma, and so gastrinoma is gonna release a bunch more gastrin than I need to be released, right? So hypersecreting neuroendocrine tumor results in hypergastrinemia and gastric acid hypersecretion. 80% within the gastrinoma triangle, so the porta hepatis, pancreatic neck, and third portion of the duodenum. And so, who's that guy? Yeah, I don't know if you had Zollinger-Ellison syndrome or not. I inherited this slide. Did you see the triangle, right? So you got the common bile duct or porta hepatis. You got the duodenum. You got the pylorus. I don't know. I told you I inherited the slide. He might have had Zollinger-Ellison syndrome. So gastric location or gastroma locations, pancreas, duodenal wall, and lymph nodes. Common in patients with the MEN1 gene, and so that's multiple endocrine neoplasia type 1, and aka Wermer syndrome. You guys heard about Wermer syndrome? So they got they're tired. They get stones, kidney stones. They get PUD symptoms, they get broken bones, and they get pain. I had that on this slide too, but it didn't update. So all my cool guy things, extra things to look at are not there. Zollinger-Ellison syndrome, 90% of ZES patients develop peptic ulcer disease, obviously, because they've got an additional hydrochloric acid that isn't supposed to be there. Screening with fasting gastrin levels. So there's a new one. I want fasting gastrin levels, and that'll tell me if I have too much gastrin. I want to do that for patients refractory to ulcers or in patients with peptic ulcer disease with the family history of the MEN1. In patients with peptic ulcer disease who are not taking NSAIDs and are H. pylori negative, now I need to rule that out as well. And then confirm ZES, I want to refer them to GI. So any questions for peptic ulcer disease? and we're still doing good on time. We're only at 40 minutes, guys. So gastroparesis, delayed emptying of or absence of mechanical obstruction. It's uncommon in the general population. Mostly idiopathic, we don't know, but there's a strong link to diabetic patients, about 15%. The only ones that I've ever seen were all diabetic patients that weren't, they didn't take their meds appropriately. And so their blood sugars were all over the place. Their A1C was always wrong because they didn't take their drugs. So other causes include complications of gastric surgery. So like injury to the vagus nerve is going to cause this as well. And so it's very significant on X-rays and CT scans. You're going to be like, wow, I didn't know that the stomach could stretch out that far. And strangely enough, their cardinal symptoms are nausea and vomiting, right? Early satiety, what? I can't fit anything else in there. Bloating and or upper abdominal pain, and then weight loss in severe cases. You would think that you would have like this big old distended stomach, but actually they lose weight, so you can't really tell when you're doing their abdominal exam because they're not getting all the nutrients they need. They're basically starving. So the clinician should suspect conditions based on history and symptoms. Mechanical obstruction must be ruled out. And so what's a mechanical obstruction? Cancer, right? Something's kink in the tube. Adhesions. So remember in your history on your abdominal complaints includes all surgical history. I don't care if it's a transvaginal hysterectomy. That's still going to cause some scar tissues. Okay. So you always get the prior medical history or prior surgical history because a lot of those adhesions, anybody who's got like abdominal surgery, they get, adhesions. I never know why people would do like a voluntary, like a gastric bypass surgery because that's always ending in bad things too. So just stop feeding the face, So, gastroparesis, acute exacerbations require decompression, but sometimes you can't get everything out because you've got like big boluses of food that aren't going to suck out well with that small little tube. But you want to give them IV fluid and electrolyte replacement. You could probably consult GI to go in there and use a larger bore suction to try and decompress the belly. They don't like to do it though. So there are dietary modifications. Like later, I want them to eat small, frequent meals. Avoid high-fat foods. Avoid carbonated beverages, alcohol, and smoking. Optimize glycemic control. And then prokinetic medications. So you got Reglan that kind of helps things go down the tube. Doperidone. Have you guys seen that one in farm yet? So it's a dopamine agonist or something. Somehow helps the stomach drain. And then erythromycin is also a prokinetic. So gastric adenocarcinoma, very common, one of the most common cancers worldwide. We get 22,000 in the U.S. annually. The highest rates are in Eastern Asia and Europe and South America. It affects men greater than women. Generally asymptomatic until advanced stage. So like, they don't have any symptoms because you only got like this tumor growing, right? This like little thing inside the stomach. It's not going to really bother you until way later, until it's metastasized, when you start getting bone pain. Your symptoms may include dyspepsia, new onset. And so I don't like that he had patients greater than 50 because if you remember in my dyspepsia slideshow, one of the alarm features was greater than 60. So we'll drop that down to greater than 50 and call it good. You guys agree with that? Yes. Epigastric pain, anorexia, early satiety, unintentional weight loss, dysphagia. So now it's hard to swallow foods. Upper GI bleed, lower GI bleed, and persistent vomiting. So your physical exam is typically unremarkable. classic signs of metastatic disease are Sister Mary Joseph nodule, which is a metastatic paraumbilical nodule, firm consistency. Any prior medical people ever seen this? No. And so sizes range between 0.5 to 15 centimeters, may be painful, and may have discharged fluid. And so I looked up who the hell Sister Mary Joseph was and why she had a nodule named after her. And she was actually a nun in the 1800s that was a surgical assistant. And she made a note that like all these patients that had like poor prognosis usually had this stomach lesion or this lesion in their umbilicus, and it was associated with gastric cancers, anything in the stomach in the female reproduction area, pancreatic cancer, all of those. Virchow node is a left supraclavicular lymph node enlargement. And so that is pathognomonic for gastric adenocarcinoma. Okay, and so when you're doing your lymphatic checks, anytime you have cancer, usually you have lymph node involvement, right, in later stages, and so you're going to have lymphadenopathy somewhere. And then you see the ugly little thing poking out of the belly. You know, you guys have the same parasitology video that we had about the dude who had like the botworm that he would feed with the steak, no? And the massage therapist that went to the toilet and she had worms that were clinging and when she was, no? Okay. I had fun videos during my iPad time, so. Diagnostic studies, I don't know, I think it's because that reminded me of the bot fly, sorry. So diagnostic studies, lab CBC often shows anemia. CMP, your LFTs may be elevated because you know it's right next to the liver. So endoscopy to confirm. Other radiographs warranted. So if I'm thinking metastasis, I'm going to do my CTs, my MRIs, my PET scans. Most of these abdominal cancers metastasize to the liver as well, and so that's one of the things that you're going to look for. And then the peritoneal area, you can have metastasis, like little speck lesions throughout the stomach lining. And then the PET scan's good for the bones, right? Treatment is surgery, chemotherapy, radiation, or combination. So that's adjunct therapy or adjunct therapy. Prognosis 5-year survival rate is 28%. So, you know, they die because again, it's late. So gastric lymphoma, this is a secondary tumor that's spread from non-Hodgkin's lymphoma. Primarily tumors arise from malt, and so that's the mucus-associated lymphoid tissue. It's associated with chronic H. pylori infections, and then presentation, diagnosis, and treatment similar to the adenocarcinoma. At carcinoid syndrome, you get a carcinoid tumor. It's a neuroendocrine tumor originating from the digestive tract or lungs, and those neuroendocrine tumors do lots of weird things, right? So the carcinoid syndrome constellation of symptoms mediated by various humoral factors that elaborated by some carcinoid tumors. And so cutaneous flushing begins suddenly, lasting up to 30 minutes, involves the face, neck, upper chest, associated from mild burning with a mild burning sensation. You get venous telangiectasias, some diarrhea, and then watery, non-bloody with abdominal cramping. And so when I did my derm rotation, I had this really cool dermatologist. He started his career off as like an enlisted something or other, and then went and became a pilot, and then went to USHUS and became a physician, and then dermatology rotation. So like he was bleeding green. And he told me, like, you know, most systemic diseases always manifest in the skin. And so, like, you might have some weird things, and it'll probably manifest itself somewhere in the skin, like hyperthyroid. You know, you get those anterior tibia weird things, right? And so the cutaneous flush with that endocrine neuroendocrine system, that's gonna affect other things, right? Any questions on that? No. All right. So quick note about kids. You guys have heard of pyloric stenosis? Yes. More specifically, infantile hypertrophic pyloric stenosis, but we're going to just call it pyloric stenosis. Classic presentation, 3 to 6 year old child. Usually it affects the first male born to that couple, and then the first 3 to 6 weeks of life, they might have immediate postprandial projection of their food, and then they're hungry right afterwards. And they can't eat because they've got this tightening of the pylorus, so nothing's going down, and so they may be underweight, have some failure to thrive. But usually parents that are getting projectile vomited in the face will bring them right in, right? And so we can diagnose it. Physical exam will reveal that undernourished, dehydrated child. And then you'll have that palpable olive in that right upper quadrant, which shows you that hypertrophic pylorus. And then you've got the olive sign on ultrasound, because I don't want to irradiate a kid in a CT scanner, right? I want to decrease that as much as possible. So for most surgical abdomens on babies, it's all done via ultrasound, unless the surgeon requests things, okay? So I got that olive, and then the treatment is surgical pylorotomy, pyloromanotomy. And so what they basically do is cut one of the muscular layers at the pylorus to open things up, just like they do for achalasia, right? They cut down on one of the muscular layers so it opens up that sphincter and allows the food to go through. Very simple procedure. Maybe I need to talk more and pontificate more, right? But I got nothing else. So you guys have another hour and